Keep coming. Hey, Mindy. Nice to see you.
Nice to see you too. I also never tested positive for COVID, just so you know.
Yeah, lucky. All right, so this is today's talk. We're going to be reviewing Kratom and special guest 7-hydroxymetragenine. So it's going to be tons of fun.
All right, some upcoming talks. It is going to be Kurt and I believe Alex coming up on the November 12th session, doing some case reviews of some interesting patients that they've cared for in the clinic. And just a reminder, we do not have Echo November 26th. So if you do sign on, we won't be here. Sorry. And then feel free to check out the other echoes listed at the bottom of the previous slide if you're looking for extra continuing ed or just a knowledge gain in general.
Go ahead.
Go ahead, me. All right. We're always here for technical assistance. Feel free to reach out, text, call, email, whatever the easiest way is for you to get a hold of us. Happy to help with any challenging patients or cases. And then we do have the Center for Opioid Resources and Education through Stratus Health. So don't reinvent the wheel. If you have needs for policy, protocol, workflow, check this out. It's a pretty good resource. And if you can't find what you're looking for, just let us know and we'll try and help as much as we can. And we do have some Zoom polls as we're getting started, but before, and as Katie's putting those up, if everyone wants to turn their cameras on, we always throw out there. We don't mind if there's children or pets or you're eating your lunch. This is pretty laid back. We just love to see everybody interacting and enjoying the session with us. So, which of these best describes your role? All right. Looks like provider and nursing driven today. Thanks for the response on that one. And I think we have one more polling question. Probably drives Katie nuts how there's a lag. As part of your role, all right, looks like most of us on the call are working with MOUD patients. Awesome.
All right. All right. Is that the actual, are you ready to go, Katie?
Sorry, what was that?
Is this the actual
Yep.
thing? Okay, good. I thought maybe there'd be a delay. So yeah, so thanks everybody for coming. Um, Most of you know me. My name is Kurt Devine. I'm the medical director here at Addiction Services at Centric Care. And we're going to talk about Kratom. Just as an aside, the next one we're going to do in November is a series of cases that we used for a boot camp that we've done, and they're just kind of fun. It's very interactive, and they're just cases of all different types, different ways people show up at needing Suboxone. So that one's, I think, going to be a lot of fun, just so you can kind of see how we do it. So today we're going to talk about probably my favorite topic, which is Kratom. I have given talks on Kratom for a long time, and I follow the Kratom data constantly, and just always am getting the up-to-date stuff. I can tell you 10 years ago, there was very little about Kratom and very almost nothing study-wise. And so more and more stuff is coming out. So I think it's nice to kind of get a general review of what Kratom is so people kind of understand where this whole thing's coming from. And just kind of some of the latest data, and then we're going to dip our toes into the metabolite of metragenine. And again, you could say some people say these words differently. Some say kratom, whatever, and metragenine people say different ways as well. But Then we're going to talk about 7-hydroxymetragine, which is the metabolite of metragine and probably the actual opioid in the kratom. So as you all know, it's come out as a synthetic, and it's quite powerful. It's really, I think, changing the game. Next slide. So when we talk about this, we want to kind of review some of the kratom stuff, and you can kind of look through these objectives. But again, at the end of this thing, we're going to talk a little about 7-HMG, which I'm going to say that because it's a lot shorter than 7-hydroxymetragine. Next slide. And again, feel free to turn on your cameras. It's much more fun to talk to people's faces, so you don't have to, but keep that in mind. So kratom is something that's been around forever. I think when we often think about how people use things, it's interesting that much like coca leaves, where people would chew on coca leaves before they would go to work, people chew on the leaves of this tree, and these evergreen trees are related to the coffee plant, which you'll see me bring this up down the road because later on in the talk, the Association for the Kratom Association talks about how kratom is just basically another coffee, which I think most of us that have seen it kind of understand it's not. It's really native to Malaysia. That's really where it's been at most of the time. But now it's literally grown all over the world, and that makes a difference, and we'll talk about that a little bit later. As most of you know, this has both stimulant and opioid properties, and it really depends a lot on dosing. And again, we'll talk about that. Next slide. So the main active components of this are alkaloids. And so metragine and 7-hydroxymetragine are considered kind of the active components. As it turns out, metragine itself is much less of an issue and probably doesn't really attach to the mu receptor nearly like 7-hydroxymetragine does. And that was something that has just really come out in the last few years. Really prior to, I think, 2019, 7-hydroxymetragine hadn't even been described. Partial agonists, again, at the opioid receptors, but again, probably more 7-HMG than metragine itself. Next slide. So the other thing is, it often makes me think about marijuana, because when we think about marijuana and we think about all the different things in marijuana, and we just talk about a couple of the cannabinoids that are in there, when there's actually over 100. When we think about kratom, it's really important to understand that, sure, we got a couple alkaloids in there that we know, but there's a lot of them that we don't really know what they do. So there's another 48 of them that we haven't talked about, at least, that we don't really know what they do in your body or how they pharmacologically act. So understand that it can be a little different. As you can see in the picture, there's different colors of this. And often patients will say to me, I'm taking the green powder, I'm taking the brown powder. And basically, it depends on what species of the tree you're getting. These leaves come off 3 different species, and they can be slightly different as to how much of the active ingredients they have, and they can also be a different color. And if you go to the head shop where they'll give you free samples, at least in our town, which is fabulous. I've been in there a couple of times. They just keep giving them to me. But I think that they'll say, oh, the green type is this, and it's better for anxiety. And they'll tell you basically based on the color of it, what it's going to do for you. Kind of like marijuana, where there's ones that are, oh, this one's better for this one's better for that. No research, obviously. Next slide. So here's the interesting part of this. Now, since they've started growing this tree in other climates and other places, it's changed it. And so previously, when it was all from the same area, from Malaysia, it would always be the same. And we know that if, depending on where it's grown and what the soil is like and which tree it is, everything can be a little bit different depending on where it's actually grown. And so that really makes a difference. It's not all the same. And again, the production method can be wildly different. And now we have some that's fortified. And I think originally when the fortified stuff came out, I thought that somehow they were just concentrating more what was in the leaves. But in fact, more and more, we're seeing these fortified kratom samples that actually have synthetic 7-hydroxymetragine. So understand that all these products are different. And I have a little slide. There was actually a study done on 300 different types that are being sold in the US and how, what exactly you're getting. Next slide. So they can be very distinct from opioids. And I think that's what we need to understand is that they do attach to the mu receptor, but they are much different and very distinct, okay? They have a lot of overlapping, but not identical effects of the opioids. And again, much of that is based on the dose that you take. Often in the literature, you'll see them referred to as atypical opioids. So understand that if you see that in the literature, often that's what they're talking about. Next slide. So how is it used in the US? I can tell you the first time when I saw it, probably 10 or 12 years ago, people were taking capsules that they were buying at the head shop. And I had a number of people early on that were buying it on Amazon by the kilogram. And they would buy the powder by the kilogram. And often people would use it in a liquid form. I had a lot of people that would use it at work and put it in their water bottle and then just shake it up before they drink out of it. But tea has always been a really popular thing. And I actually had a guy last week who said to me that he hated the taste of Kratom, that it tastes so terrible, you have to put a lot of sugar in it if you drink it as tea. So most people that if they drink the tea, it's not really even an acquired taste. You have to put something in it to make it taste better. Interestingly, there have been case reports of IV use, which I wouldn't recommend. And there's also a number of cases of people smoking it. And I actually got a kid that I see right now who's not doing so well, who's been smoking Kratom. In the literature, there's very few case reports of that, but it is relatively bad for your lungs. I've seen it one other time in St. Cloud, and we had a patient that was in the hospital from smoking it, and it was pretty epic how sick she was. Next slide. So there was just a recent study done by Hill et al., and he talked about what appeared to be the 4 main reasons that people were using Kratom. The first group was really the self-treatment for chronic pain, and we see that a fair amount, and that's probably a third of the patients at least are transitioning to that when their opioids are tapered off, or if they can't get opioids and they think that their pain needs to be treated. It's a pretty big group. We see a fair number of people that are self-treating their substance use disorder. And I can tell you, even the first patient I saw, whom I actually still see, when she was taking it, she was actually pregnant. And she had switched from heroin and thought she should switch to Kratom because it would be safer for her baby. I'm not sure it was. And so she switched off to buprenorphine really pretty quickly. There's a third group that clearly are using it recreationally, and that's about a fourth of the crowd. Most of the people that use it recreationally like this, that are using it intermittent, would fall into this group where they don't really have that history of substance use disorder. They'll occasionally take it when they're with friends. They might take it, if they're really anxious about something, but it's not something that they use regularly. The last group, of course, is the recreational group, and we see quite a few of those. I think about one person in particular that I had on Suboxone and came back and surprised me by telling me that he'd gotten off his Suboxone by taking Kratom. And it didn't go well for him. The Kratom spiraled out of control. And one of the things about Kratom, when you're using it for recreation, you're using it frequently, is you build tolerance to it, or at least some people do, very quickly. And if you do, you have to really use it a lot, and it is expensive. And so it's not uncommon for me to see people who are using enough to spend $100+ a day on Kratom. Especially, we'll talk about the 7-hydroxymetragenine. That's quite expensive as well, and we've seen people spending quite a bit. Next slide. So I think when we look at group 1, it's interesting that this group tends to be older, what you'd expect if they have chronic pain. If you look at groups 3 and 4, they're more likely to be women. So the people that are using it recreationally, intermittently, and the people that use it recreationally frequently, they tend to more likely be women. They are more likely to blame kind of the medical people for this lack of access for chronic pain. And that's roughly half the people. I mean, it's pretty stunning. Group 2 was actually the least likely reason to use kratom, but more of those respondents had reported previous history of substance use disorder, and again had transitioned to kratom. So this is a group of people who had a substance use disorder and were basically treating it themselves, or at least they thought they were treating it themselves. Next slide. So group 3, again, one of the recreational groups, they had chronic pain less often. These weren't people that were taking it for pain. But again, as I mentioned, they often didn't have any history of substance use disorders that really needed to be taken care of. These are the people that just kind of intermittently use different drugs, and kratom is one of those drugs. But again, occasionally for that mild anxiety, it's like maybe I got a test coming up and I feel like just taking a little kratom and just taking the edge off. And again, at the lower doses, you can do that and really not get the opioid effect. The last group, of course, is the group that is using it a lot. And those patients like the high that they get with kratom. And people will tell you, especially if you take a big dose very quickly, that you will get that very relaxing high from it. They're more likely also to at least have moderate to severe anxiety. These people are the highest probability of developing a kratom use disorder, which I thought was pretty funny that they put this in this paper that I was looking at that talked about this by Hill. You can't use kratom use disorder and get paid. It's not in the DSM-5. If I put it in, it just comes up in our system as not found. And so often, again, we use opioid use disorder for this typically. Next slide. So all 4 of these classes were very likely to use kratom to also, again, help performance. And by performance, it's just, again, it's like taking that edge off. Maybe it's to get through their workday. Maybe it's just because school, they have tests and they want to take the edge off. Some people believe that when they take this, it improves their physical performance, which I think is not something I've really heard, but in the surveys, that's something that came up kind of repeatedly. Next slide. So who's the average person that's using this? The average person is actually a little older than I think most of us would think. And I've seen people even in their 60s and 70s using kratom. So it's not unusual to see the older group, especially ones that have been taken off their opioids. But the mean age is actually 40. This is something that is basically a disease of white people, Caucasians, and 90% of the users, frankly, are white and female. Female 61%. I would have to say my personal experience has been it's more often men. I have not seen a lot of women using it. I've seen a few, but I would have to say more often men. And then maybe because of the particular crowd that we're seeing are people with substance use disorders and not some of the other groups that are more often women. Daily use is almost 60% when people are using it. So really very commonly used daily. Next slide. So how is it metabolized? And that's part of the problem with kratom is that it's metabolized in a way that often interferes with other things. And we have some slides a little bit later about some of the things that we'll interact with. But it's that P450 that kind of messes this up. When you think about how people use this when they're using it as a tea, the half-life is right around a day. So you can imagine this lasts quite a while if they're taking it as a tea. When people are using it as powders, for whatever reason, the half-life is much quicker. It's generally about 3 or 4 hours, although there have been some studies more recently that showed that it was a little longer than that. Some of the stuff that I came across as I updated this talk really showed that the peak of 7-hydroxymetragenine and metragenine is frequently right around an hour. So it comes on very quickly and it kind of reaches its peak. Again, the active metabolite, the 7-HMG, was not really described until just about 6 years ago. And so prior to that, nobody really understood that that was kind of the main opioid mu problem for us. Next slide. So how about the absorption and distribution? Well, man, there's not a lot of studies. Most of the studies have been done on this have been done in rats, and most of us don't treat rats. but I think that we hope that it kind of crosses over into the humans. Um, Again, the peak plasma concentrations that were noted in some of these, again, right around that 1 hour. Next slide. And that's kind of what's continued to be shown over the last couple of years. But it's got a very high volume of distribution. So we believe that it goes out of the circulatory system. It's not highly bioavailable. So of all the stuff that you take, unless you do it IV, it's only about 3% bioavailable. And it's not really water soluble. So for instance, my guy who was drinking out of his water bottle, he would tell me that he always had to shake this. Otherwise, it would all settle down at the bottom. And so it doesn't really absorb well into the water, but it is a little bit lipophilic. But when you talk about lipophilic drugs like fentanyl and marijuana, those will cross the blood-brain barrier. This is protein bound, and so there's really this question of like how much does it get into the brain, which really has been as of yet not answered. Next slide. So how about the pharmacokinetics? One of the things over the last decade that's been talked about repeatedly is the fact that there aren't a lot of overdoses with this that are specifically just from kratom. And I have slides about that a little later on. But just understand that the medium effective dose is about 20 times less than what's considered a lethal dose. And so people rarely can get to a level or take enough to really cause that unless it's a drug interaction or a cardiac issue, a QTC thing, or some of these other things that will cause sudden death. One of the questions that I have that has not been answered yet is this 7-hydroxymetragenine going to change that? Because of how quickly and how high the levels go of 7-hydroxy when you're actually, I don't know who's trying to get hold of me here, but they're going to have to call me back. 1 second. All right, sorry about that. But again, kratom deaths are more likely drug interactions, and I think that that's the thing that we have to kind of hang our hat on. Next slide. So in a perfect world, why are people coming in? What are they saying as to why they take this? And the answer is a lot of people just feel better on it. They're more social. They feel like they're more alert. There are a lot of times where they are talking about this and they feel like it actually makes them concentrate better. And so if you look at some of the ads where they're selling kratom, they actually say, oh yeah, this improves your cognition. This really improves all these other things. And again, at higher doses, it's that pain relief that people get that they're really looking for. Next slide. So one of the interesting things with kratom is the dose you take can really change the experience you have. And so when we look at people taking that 1 to 5 milligram kind of area, and again, how this is not something that is closely regulated. So these doses may be different depending on what you take and how well they're absorbed. And so we really don't have an idea as to whether or not that's going to make a huge difference for us. We know that if people take larger doses and they have higher levels of 7-hydroxymetragenine, that they get much more of the opioid effect, and with that, the depressant effect. And so, again, dose matters, and it makes a big difference as to how people feel and what kind of response they get. Again, one of the problems is even if you start low, often because your tolerance goes up quickly, it's sometimes hard to stay in that low level, but people do it. And again, some of the data we show you will show that that's the case, that there are a lot of people who will take low doses of kratom for a prolonged period of time. And for whatever reason, they don't take more. And I think the people that end up seeing all of us, they've kind of selected out, and it could be genetics or metabolism, where they end up really kind of going off the rails a bit and taking much, much higher doses and then developing horrific withdrawal. Next slide. So these are the effects when kratom is used intermittently and really, not in conjunction with other substances. So when people have a problem with this, they call it poison control. And it's extremely interesting what has happened and what has been seen by poison control and how that's changed over the years. Next slide. Initially, I think back from 2011 and 2017, calls to poison control for kratom were really very infrequent. And if you look at that, let's say there's 1,200 over that 5 or 6 years, and that's maybe a couple hundred calls a year. And that was kratom only exposures. And 1,000 of those people had some pretty significant adverse clinical effects. If we look at today, 2025, in the first 7 months of this year, there's been almost 1,700 calls. Okay. So that's 7 months compared to 6 years. And we already have, this has gone up 10 times the number of calls just in the last few years. Interestingly, in that same time period, in this first 7 months of 2025, they've had 165 reports of the 7-hydroxymetragenine exposure, and almost 70% of those people they referred to the hospital ended up getting hospital care. So I think that, again, we're going to see the 7-HMG kind of take over, and I think that we're going to see some problems associated with that maybe we did not see with kratom. The other thing is that people, when they call, how many of these people had kratom that actually had 7-hydroxymetragenine in it? And the reality is we don't know, because more and more of those now have it. I'd say the majority. Next slide. Again, more than half, about 50% of these cases require treatment, including IV fluids, benzos, oxygen, even naloxone, some with intubation. These can be pretty significantly sick people. And again, I think my hunch is that the ones now that we're going to be seeing that really have problems are going to be more the synthetic 7-hydroxy. Next slide. The most common reported effects, and it's interesting because my coworker Alex had just had a patient who was, I think, on kratom and was twitching, which is not part of some of these lists, but I think most often you're going to see the tachycardia, most often probably vomiting and confusion. Those things are pretty common. Drowsiness, often people take this and they feel like sleeping. But I can tell you that I see people that are using this 4, 5, 6 times a day, much like people would use fentanyl because they built up enough tolerance. So they're using it a lot. Often you see these things when people aren't really tolerant to it and they've taken a big dose. Next slide. And again, some of the worst clinical effects, seizures have been reported, rhabdo, renal failure, all kinds of fun things, cardiac arrest. And so the kratom itself, or the 7-hydroxy, clearly at high doses, or if people have no experience with it and don't have tolerance, often can result in pretty serious troubles. Next slide. Yeah, if your EKG goes flat like that, that's typically a bad sign. So some of the non-acute side effects, much because of the mu receptor stuff, you're going to see the constipation, you're going to see the depression. Occasionally, people have reported in the literature significant liver toxicity with actual jaundice and itching and dark urine. So again, don't discount the troubles that we can have with our urine with this particular drug, and the constipation and other things that we would see typically with an opioid. Next slide. So what's the CDC going to say? How'd they weigh in on this? Well, they looked at some data on unintentional and undetermined opioid overdose deaths. So this is a study that's been quoted rather widely. And I think it really kind of shows something that I wish it didn't, but it's the reality that there are very few deaths with kratom itself without the synthetic 7-hydroxy. Next slide. I do find this kind of interesting. If you look at the data from 11 states from July till June, so a year, and then they took the data from 27 other states from July to December in 2017. So they just looked at these 2 time periods, and why they picked these, I have no idea. But if you look at this, there was 27,000 overdose deaths from what we consider opioids during that time. So during these particular time period. Next slide. And if we look at those deaths of 27,000, 152 of these cases had kratom detected on postmortem. So it was just detected. It was not the only thing in their urine. Kratom was actually identified as the cause of death in 91 of those cases, so a little more than half. But in 7 cases, it was the only substance detected. So in only 7 of those cases Kratom was the only thing in there. More often than not, these are people who polysubstance use, and they have a lot of things in there. So Kratom may have been identified as the cause of death with something else, but it may not have been the sole thing that caused their death. Next slide. And if we put that into perspective, in 84 cases, they had co-occurring substances. All of these different things were found in there: the cocaine, the alcohol, again, things that are going to, like alcohol, they're going to be a depressant, heroin and fentanyl, they're going to slow their breathing down and cause those problems for us. Next slide. So this is actually a study that's often used by the American Kratom Association, and we'll talk about that in a minute. And it's because it shows how safe Kratom is, right, and compared to opioids. When the reality is more people are using opioids than Kratom. The Kratom numbers are somewhere around maybe 2 or 3 million people they believe are using it. I think that's way undershot. Next slide. I think it's way higher than that based on what we're seeing. The interactions are the thing that really we have to worry about the most, and especially if you're doing psychiatry and you have people on different meds that may do the P450 metabolism. And so those things like Seroquel, those things like SSRIs, all of those things can cause interactions with Kratom and potentially cause sudden death. And so it's really something that when we talk to patients, we want to make sure that they're not taking something that they think is an herb, if you will, to also help their mental health or their pain. Next slide. What do we do with these patients? What happens if they show up and they overdose? It's amazing that there's not really any studies on whether naloxone works, but everybody uses it for Kratom overdoses, and there are quite a few reported cases in the literature of people Narcaning patients with clear Kratom overdoses and having a response. So I think that's something that we have to consider right away. If somebody brings somebody in and they're not doing well and they've been using Kratom, Narcan would be top of the list. Again, if they develop acute hepatitis, there's different treatments to N-acetylcysteine, but for the most part, I think naloxone is the thing that we have to always remember with Kratom. Next slide. And I think probably more so with 7-hydroxy. What's this withdrawal like? Well, the interesting part of this, and I didn't really put this in there, but if you look at the studies from even 4, 5, 6, 7 years ago in the different papers, if you look at all people who use Kratom, there's pretty good evidence that most people don't have severe withdrawal when they stop Kratom, which again, I find very hard to believe. But again, the patients that are coming to our clinics for help are probably people who, for whatever reason, are either using more, have some kind of genetic predisposition to have worse withdrawal. It's just hard to know whether they have some metabolic thing that makes their withdrawal look terrible. My personal opinion is I've seen people withdrawing from Kratom that have been just as bad and a little bit more difficult to treat than with fentanyl. They can be horrifically sick. In general, the long-term use of withdrawal starts roughly 12 to 24 hours, and it lasts 3 to 7 days. And in fact, there's been NAS actually reported in infants who've been born with mothers who are using Kratom. So causes very similar symptoms to the opioids in the infants as well. Next slide. Or not, Katie. So symptomatic treatment, just like we would for any opioid. Again, there's been a lot of literature about using buprenorphine and methadone. I can tell you 10 years ago, it was a big question mark whether we should be using buprenorphine for Kratom. And when I started doing it, there were people that said, well, I don't know if I'd use it for that. And it's like, these people will relapse. They go back to use. And so I do think that buprenorphine works very well for these patients. And to be honest with you, these are some of the patients that actually get off buprenorphine over time as compared to fentanyl, where I often don't even expect it or talk about it. Next slide. There's some evidence, and I underline some, that there's less potential for dependence and overdose. And I think that pretty clearly the overdose data for Kratom is not shows it's not super high. It's also interesting that if you look at the patients again that are using it, again, prior use disorders, and it may not be specifically opioids. There's a lot of alcohol and kratom. And when I talk to kratom patients, very frequently they're also drinking alcohol if they've not had a previous opioid use disorder. Next slide. Now, what's the incidence of actual dependence or use? Well, again, there's no reporting systems, and a lot of the use data is coming from surveys. There's no great way to tell. There's not good data on sales and how much are people using and, all of this stuff. So it makes it kind of a gray zone. In general, when the dependent symptoms are milder, okay, but again, the same medications can be utilized for treatment. So it really depends. If you have a kratom patient and their withdrawal, I had a guy who withdrew from kratom and he was taking quite a bit, and he almost had no symptoms at all. And he was using a lot. And in fact, the same guy then stopped drinking alcohol and he was drinking, a fifth a day, and he had no withdrawal from alcohol. Can I explain that? I really can't. But I just think that we need to understand that the withdrawal symptoms for patients using kratom can be vastly different. And it's just important for us to understand that if somebody believes that they can stop, the patients we're seeing are the ones that can't stop. We rarely see the people who can stop. But I have occasionally when they say, "Oh yeah, I used to use kratom. Man, I was spending $100 a day, and I just stopped at cold turkey, and I really didn't get that sick." And it's like, well, why? I'm not sure I know. So next slide. So what are the other risks? Well, there's no regulatory oversight of this. So how pure is this stuff? Nobody knows. What's the quality of this product? Nobody knows. What's the potency of this from brand to brand? Nobody knows. Does it matter how many milligrams it says it is in there? I don't think so, because it's mostly an estimate based on the weight. And again, there's very little assurance of safety. And that is, that may seem like a small thing, but if you want to change to the next slide, Katie, if we look at this, many of these cases that are reported in the literature show that often the kratom is adulterated and it's being sold in still gas stations and smoke shops, but it actually has had stuff put in there that it's not listed on the ingredients. And one of those would be 7-hydroxymetragenine that's actually put in there, but not really listed as part of its part of the kratom. So when you buy kratom, it doesn't mean it's just kratom. And there's other substances that have been added as well. And both of those different synthetic substances also have been attributed to patient deaths in the past. Interestingly, multi-state salmonella outbreaks have been linked to kratom, and heavy metal contamination has also been linked to kratom, most commonly lead. Next slide. Lead isn't the only thing, but it's certainly been a problem. If you use more than 50 grams of kratom a day, that's a patient that you probably want to check their lead level on. Obviously, this is a bigger problem if somebody's a teenager and using it and their brain is still developing and they have a little lead in there. There's also been nickel in some of these, and there's also been cadmium in a number of these samples, significant amounts of cadmium. So think about those things, especially if somebody's using kratom and is confused. Make sure that lately, but have. Next slide. Interestingly, this guy, he goes to 8 kratom products and looked at in Chicago, and he found all of these different things and iron. So again, the lead is probably the one we worry about the most, but this was an actual study of things he bought in Chicago. Next slide. Next slide. We talked about that already. So again, the 50 grams is kind of the line, if you will. Actually, I think that if you look at 7-hydroxymetragenine, because it's synthetic, those products are probably not a big issue for the lead. And I think it's important to understand that. Again, larger doses cause GI symptoms normally. So again, with lead, you can get some of that as well. So it's often going to be difficult to know which is causing it. Is it just the kratom alone, or is it that they got some of the stuff that's got a lot of lead in it? Next slide. So this is an interesting study done by Smolitz, and this was actually this year. There's some good stuff that's come out in the last year. And this is a guy who was just looking at the evaluation of the case reports that were coming out by looking at PubMed. And they looked at this literature and kratom use and just, what kind of adverse effects are we seeing? And they actually only found 95 patients identified that kind of fit their criteria to kind of review. There were case reports for kratom use. Next slide. So of those 95 people, 55 had confirmation of the metragine on toxicology. And interestingly, I just had a patient yesterday who was telling me at Teen Challenge, they actually have a dip now. It's part of their urine cup, actually has metragine on it, which I have not seen, but I'm going to look into. So 55 had confirmation of metragine. 20 of these patients survived hospitalization. So some of them did not. 35 cases of this were fatal. And if you look at the fatal cases, 95% were male with an average age of about 30. And again, in my experience, it's been more often males using large amounts of this than females. Now, the most common ingestion method of all these patients that ended up hospitalized and the ones that died was actually powder or these new kratom soft drinks. And I don't know if you've seen those in holiday stations, but they're in a number of the gas stations now. Next slide. So 8 of the patients actually had cardiac events and actually found at autopsy had all different types of cardiac anomalies or had had a heart attack. The most interesting part of what they found is that 7 of these people actually had cerebral edema or other brain findings. And again, seizure is something that's associated with kratom use. And I do think that that's something to think about. And again, these numbers are small. We don't know, again, from a USA standpoint, what's the number across the country? It's difficult to know. 4 of these people had GI issues, including vomiting and aspiration, abdominal pain, and all these kinds of things prior to their death. Next slide. So of those fatal cases, the 32 that had other substances in their systems had the usual suspects, the things we talked about earlier. Benzos, SSRIs because of the interactions, opioids because of respiratory depression, and again, the antipsychotics because of some of the interactions we see with things like Seroquel and other antipsychotics. So those things were not a surprise compared to what we kind of knew from the last 10 years. Next slide. So here's another one. The kratom. This is really pretty shocking. This kratom risk compared to opioids, and this was done by Smollett's. This was in 2025. This is just hot off the press. This guy actually pulled this kratom use from 2018 and 19. He figured there was roughly 2 million adults. Right, that's estimated. Again, my hunch is it's a lot more. And when they looked at the death rate from kratom use and looked at death rates in states, they felt like the death rate would probably be about 0.3 deaths per 100,000 users of kratom. So as you can see, that number is really pretty small. When we think about comparatively, death rates for heroin were 4,700, 48, almost 4,800 per 100,000. And this is why the Kratom Association puts things in there and says how safe it is that really the death rate is really pretty small. But this is kratom use from survey data. And so we don't know. The number could be 3 million, 4 million, 5 million, but that would even make the numbers better for kratom. Maybe the death rate was 0.2 and not 0.3. So I do think that it bothers me to see this because I want to say to patients, look how many people this has killed. I think more often it's about the morbidity and maybe not the mortality. Next slide. Now, because really the bottom line for me is that kratom is a substance that's used, right? And there are certainly deaths from it. And again, the number of deaths is probably small, compared to fentanyl and other opioids. But I think anecdotally, when we're seeing the patients with kratom, they have a lot of medical complications. They may not die, but they're sick. They use up ED time. They use up other time. And people clearly get addicted to this and dependent upon it and have pretty severe illness with withdrawal. So I do think that, yeah, I'm going to agree with the AKA, the American Kratom Association, that probably there aren't a gazillion deaths associated with this, but I do think that the medical complications from this medication are pretty significant. Next slide. A lot of people say, well, it's okay to use it because it's harm reduction, right? What if we didn't have people on fentanyl? They're going to die less, right? And so should we be giving people kratom and not buprenorphine? And there's some people that say, well, it's a great option if somebody doesn't want to see a doctor, because 15 to 20% of the people using it are taking it as a replacement for opioids, as a way to decrease their opioids. And again, I do think that their death rate is going to be lower, but is their rate of other medical complications going to be higher? And again, I think that's something that's going to really kind of be worked out over time, because again, the kratom deaths are probably going to be more often associated with drug interactions than they are overdose. Next slide. So what do we know about 7-hydroxymetragenine? It looks like I got about 10 minutes left. The reality is not as much as we should. There is not a lot of great stuff about this. Next slide. And that should scare us all because it came on pretty fast. All of a sudden we're seeing this. And I'll tell you, one of the first patients I saw who took 7-hydroxy was actually taking metragenine. He was taking kratom, and then he decided to buy 2 pills, 60 milligrams of 7-hydroxymetragenine. And his exact words to me were, I lost a day of my life after I took that. I can't remember a thing. And he basically took them, and he doesn't remember a thing until the next day when he woke up. So it's a different drug. It's a more potent mu receptor. And in fact, when you look at people taking kratom, the conversion rate from metragenine to 7-hydroxymetragenine is actually pretty low and slow. But the HMG is much more potent, and it's a much better mu opioid receptor agonist than metragenine. And that's the problem. It attaches to that mu receptor, not as good as morphine, 20 times less, but 9-fold higher than metragenine itself. So it sticks pretty well to the mu receptor. It is interesting that if you look at this, the ratio in people's blood or often is the HMG is only 8% of what the metragenine is. So even though the level is much lower, it's much more efficient and potent. And so those low levels, even if you're just taking kratom, can cause significant mu receptor agonist activity. Next slide.
Rita.
Oh, yeah, somebody's got a mute there. So here's a study by Gonzalez that was done in September this last year. And in this study, they used rats, and they actually used IV metragenine and 7-HMG, right? So what they did, and this is really interesting, is they gave them that and they gave them morphine. And they wanted to look and see what happens to the breathing patterns of rats, whether they get morphine, metragenine, or 7-HMG. And what they found was that both morphine and 7-HMG induced respiratory depression. And it was, in fact, the effect from 7-HMG appeared to be 4.5 times stronger than the effect of morphine. So it is a good respiratory depressant. Metragenine itself, so if you could take metragenine out of the kratom unexpectedly, and it didn't turn into 7-hydroxymetragenine, it actually increases your respiratory frequency. So it has the opposite effect. When people were having respiratory depression, naloxone for both morphine and 7-HMG actually reversed it. So pretty amazing that the 7-HMG is a very strong respiratory depressant. Next slide. And when you look at some of the pharmacokinetics, again, the steady state of metragenine is like 8 or 9 days. Interestingly, the 7-hydroxy is faster. It reaches steady state in just a week. And the thing to understand is if we look at if you were chewing on this leaf to get your kratom, it's only 0.01% the content of that leaf or the powder that they sell. So again, 7-hydroxy in real live kratom should be very low, low, low. Next slide. One last thing, this Hill, this was an interesting thing. He actually looked at 300 products, and they were marked as kratom. And he found that that often the products contained very high levels of 7-HMG without any warning as to what people were buying. So I think that's the warning to our patients, that if you're using kratom and you're avoiding the 7-HMG, you got to make sure that what you have doesn't have it. And it may not say it particularly well on the ingredients. these are widely available and again, misrepresented as to what's actually in them. Next slide. That again, the levels of let's say that the levels of 7-HMG are higher than what would normally be found in the leaf powder. The only possible way that can happen is if they added synthetic 7-HMG. That's the only way you can get a higher level. There are not trees of the 3 species that put out ones with high 7-HMG. That doesn't exist. It's all synthetic now. Next slide. Quickly, I just want to show you this map. This shows the 6 states that it's still illegal in. This is from 2021. The green is where it's legal right now. The yellow is where there's some restrictions, and the yellow one's changed a little bit. But if we go to the next slide, you can see the only thing that changed on this slide is 2025 now. It's the same 6 places that it's still illegal. People are looking at this, and I can tell you that people are looking at it in Minnesota, whether or not this should be scheduled or whether or not there should be some restrictions on this. I sure hope that happens. Next slide. So again, there are some that are restricting it. And again, the AKA lobbies for kratom policy at a state level. They show up when people start to talk about restrictions of this. I find it very funny that Malaysia, where the initial plants and trees came from, it's now illegal to buy kratom in Malaysia that is concentrated. So next slide. Even the place where it came from. I show this just because if you look at the bottom right, it says users can develop a mild addiction similar to caffeine addiction. Well, as many of you know, I've had a little trouble with my Diet Mountain Dew, and frankly, I didn't have that much trouble stopping it. I do think that people have a lot more trouble stopping kratom. Next slide. And the fact sheet, again, they often say in the American Kratom Association, there's been 0 deaths proven to be caused by kratom, and that's not exactly true anymore. They try and tell you that it's no worse than caffeine, which, again, I think we all know that's not true. Next slide. Here's the last thing I have. This is from Reddit, and I think we all know this is where the most reliable information comes from. Everybody on there just loves this stuff for the most part. It's saving lives. There are quite a few posts about it being hard to stop, which I think we'd all agree is a problem. There was a lot of stuff about 7-HMG being way better than pain medications, that you should try this. And a lot of people are switching to 7-HMG because they realize there's no lead or cadmium in it. So it's considered safer because of the lack of lead. It's synthetic. Next slide. One last slide here. This shows, this was 2018. You see that 350 calls to the poison data system. Since all of the other stuff has become concentrated, this number is now in the thousands. You saw that number early in the talk. I believe it was about 9 times this high now. So you can imagine, I was going to put a dot down here that was up higher, but there wasn't enough space as to where it would go because it would be up about 6 inches as to what's going on now. Next slide. Next slide. You can skip that. We kind of talked about that. So in summary, kratom is an alkaloid, both stimulant and opioid properties. There are a lot of interactions that can be fatal. And really, overdose death from kratom is probably not as common as I perceive. But again, the complications from this medication are significant. And it's usually polydrug with kratom that causes the deaths. The treatment of this use disorder is not well studied. But again, we all use buprenorphine for it. There are reported cases of methadone, which I have not done. Next slide. Now, I feel like 7-HG has that potential to kind of change the game here. I just really think we're going to see a lot more significant problems with that. They're fully synthetic. They're very potent. And the withdrawal from it seems to be much worse. We're all waiting for more research, and there's just really not that kind of research at this time. So next slide. I have these references, and I actually have about 6 more that I didn't get on there. I ran a little short of time, but I'll update that maybe before Katie sends this out if people want it. All right, next slide. So thanks so much. If you want to close that up, Katie. I'm happy to take questions. Kratom's my favorite thing in the world to talk about. So if there's any questions, happy to answer them.
That was awesome, Kurt. We do have a couple questions in the chat from Dr. Wilcox and Dr. Bilden. Beth asks, how does mu receptor affinity of the metragenine or 7-OH compare with buprenorphine?
Well, I'd have to look at what morphine, because it's 22 times.
Or buprenorphine, sorry.
Yeah, I mean, the morphine is 4.5 times, was it 22 times less than morphine? So I'm guessing buprenorphine would push it off. And I can tell you there are reported cases of, well, it push it off real easily. There are reported cases of precipitated withdrawal from this that are pretty epic. I have not seen it. I have had an addiction doctor tell me about a case and ended up hospitalized. So really quite sick.
Somebody treated with bupe. That's exactly my question.
Correct. And so if we didn't really go over this in the talk about how I treat this or how most of us here at the addiction clinic treat it, I tend to almost always low dose and go up slowly because I don't want to precipitate somebody on Kratom based on the story I heard. So I'm pretty careful. I'm pretty careful.
And then Dr. Wilcox asked, can you test for this product?
Yeah, and like I said, Teen Challenge now has a urine drug dip that has 20 things on it, and one of them is retragenine. I have not seen that, but I'm certainly going to look into it.
So when you do look into it, I would be interested to hear if you get any information about false positives. So
Yeah.
working in a different setting with treatment courts, somebody using Kratom, positives confirmed, and then positives that were not confirmed. And
Mm.
from that lab confirming did not have, providing also the immunoassay, doesn't have a list of false positives.
Yeah. Wow, that's interesting.
So let me know when you find out.
Yeah, I'd be interested to see that as well. And the only metragenine levels I've ever gotten to confirm Kratom, I've sent to the state, to the public lab, right? Because or you can send them, I believe, to Mayo, but they don't come back for 2 weeks. So again, it's like it's not helpful. So yeah, that's interesting. I'll have to look into that.
I'm not 100% sure that they do this, but a little bit faster turnaround for drug testing where a number of hospitals send to is ARUP. So
Really?
just another lab to look into that is it's pretty
Interesting.
amazing with the folks that they have on staff and the resources. So
Hmm. It's interesting because if you look at, and again, how accurate are these levels that they get on metragenine and 7-hydroxymetragenine? If you look at the deaths, it doesn't seem to be really related to the actual dose or the levels sometimes, which actually you see with buprenorphine as well. People can have a normal level and die. And sometimes it's interactions, sometimes it's other stuff. But yeah, you wonder how accurate those are.
those being blood levels then.
Correct.
Yeah, thanks. And
Yeah.
thanks for a great talk.
Yeah, thanks. I love this stuff. It's fascinating. Any other questions?
I have one. You talked about this being more popular in older adults. Have you seen kiddos? Are there young people that know about this?
It's funny because I have not seen teenagers using
Okay.
it. I have not had one teenager in our clinic. Now, does that mean they're not using them? No, it means they don't come in. Plus, I don't know if they make them be 21 to buy it at
That
the
was my
at the
next
holiday
question.
promotions. Does anybody know that? Colleen says no, anybody can buy it.
You have to be 18 years old. That's
18.
the cutoff. 18.
Yeah.
That's scary.
So I have yet to treat anybody under the age of 18, which surprises me, frankly.
And I don't recall the patient that we saw, one specific patient, college age, that was purchasing in, I'm trying to remember where he had it. He had it sent, I think, to Minnesota rather than Wisconsin, wherever it wasn't illegal yet. But
Yeah.
all said and done, he ended up having a pacemaker placed.
Wow.
But he died within a year of presentation. So pretty complex case, but bottom line is he was using Kratom and arrested, had a witnessed arrest with a wide complex monomorphic VTAC.
Wow.
Do Do you think in terms of the year, so the CDC report, I think, what did it say, 2016, 2017?
17, yep.
So Gottlieb was commissioner of FDA 2017 to 19, I think. So it was in that time period where those 40 something cases of salmonella were, and that he was really pushing to get this not regulated, but what is it? Um, Restricted, some type of restriction and get it scheduled, I think, and was not successful in that, I think, because of some of the data that's like, we don't know. But interesting time. I'm not sure how all of those things played together with somebody who was such a proponent of trying
Yeah.
to schedule this.
I think it's really, and again, because of our experience at the addiction clinic, our assumption is everybody's this sick, right? Because we see people really sick. And so it's hard for me to imagine that people use it and don't come in or don't get that sick or can get through the withdrawal without needing to be seen because the ones we see are so terrible, but they're selected out.
Yeah, yeah.
And so the reality, which I hate, is that there's a lot of people that take it and develop mild tolerance to it and don't overuse it. There's that. Um, and there's not enough deaths really in comparison to opioids to really fire people up. But again, I think it's a public health crisis in that it causes so many other, complicated medical problems.
Yeah.
And I think with time, especially with 7-HMG, it's going to get worse.
Yeah.
So
Is
cool.
it the National Kratom Association website that has the countdown?
Yeah, that's going on. It used to have a countdown as to when the FDA would call them back. They'd left a message with the FDA and they never got a call back, but that clock came down somehow. So
I also think it's interesting to look at Colorado, which was yellow on the map,
yes,
and where, Denver said no, the rest of Colorado said yes, or flipped that, whatever it was. But
yeah,
for a state that was all in, we'll say, for marijuana,
yeah,
interesting that they're kind of a holdout or in
yeah,
some places. Yeah.
yeah. It's really weird because there's different counties in Colorado where you can, and there's different counties you can't. Wisconsin is like, and I've actually gotten patients who went camping over in Wisconsin and then went to the holiday station to get their kratom and couldn't get it, not knowing it was illegal in Wisconsin, right? And then come back here in horrible florid withdrawal.
Oh,
Yeah, and just decide to come in and see if there's something that would help. So,
yeah.
but I wish that was us. I mean, it's just becoming so common now, just so common. Any other questions? Anything else?
Thanks again.
Yeah, love this stuff. It's just crazy stuff. I just wish it would go away. All right, everybody, we're past time, and appreciate everybody coming. And Beth, it was so nice to see you.
Yeah, nice to see you too.
It's always good to have a toxicologist hanging around. So, all right, well, everybody, we'll see you in a couple of weeks, and we're going to do a bunch of cases, a bunch of butte cases, which is fun. I think we have 10 of them, so it'll be a good time.
All right, thanks.
All right, bye-bye.